respected faculty and all the delegates who are attending this webinar. I'm Dr. Twinkle Dabholkar. I'm a professor at the School of Physiotherapy, DY Patil University, and I would be on the ergonomics in the operating room. But before we start with this presentation, I'm sure now what is ergonomics and why is important is a big curiosity. So I'm sure all of you must have experienced some neck pain, back pain after a heavy OT or after after surgeries lined up for you. So basically, it's when you're taking care of the best practice, you're looking at the best practices for your patient or the improved patient care. Just let us look at least for a few minutes, even to make your your life as well as your posture comfortable in the OR. So that is what ergonomics is all about. So when I'm speaking about ergonomics, first thing, this is the formal definition of ergonomics. Ergonomics is the scientific discipline which is concerned with understanding interactions of a human with the elements of the system. So here the main center in the operating room is the surgeon. Okay, and the surgeon interacts with, there are human interactions as well as non-human interactions of the surgeon within the OR. So the human interaction is with the patient, with the operating room team, and the non-human interactions are with the tools, instruments, the environment, light, temperature, light, just Dr. Marcus just spoke about the lights. So understanding these interactions and how these interactions, if they impede, if these interactions are not favorable, then it could give rise to problems in the OR and work-related musculoskeletal disorders. And if these interactions are favorable, they can improve the overall human well-being. So that is what understanding these interactions and making it favorable is all about ergonomics. So ergonomics basically is the science of fitting the job to the worker. So we have seen a tremendous change in the chair, okay, evolution in the chair, I would say, in order to fit the chair to the working population or the IT professionals. And we also have seen a tremendous change in the OR in the form of the modular OR, which is ergonomically designed so that there are multiple adjustable screens, there is less clutter, everything, the OT, there are multiple monitors so that, the surgeon assisting surgeons can look at different monitors. So there is a tremendous change in the OR also with respect to the ergonomics. So when do we start paying attention to ergonomics? We start paying attention to anything when you start realizing there is a problem. So is the WMSRDs. So the ergonomics are given attention only when work-related musculoskeletal disorders are reported in the population. So that's what I spoke about, that most of you must have felt that there is, you're feeling some neck pain, back pain, which is not because of any other cause. It is because of your working in the OR. So that is what I mean by work-related musculoskeletal disorders. So the work environment makes the condition worse and it persists longer because of the work environment. So there are increasing reports of WMSRDs, not only from the computer-related work professionals who are working on the desktop, but also in the healthcare. So the sonologists, dentists, and surgeons are, there is no difference. So there are lots of reports of WMSRDs in the surgeons. So here you can see there are two publications I would like to share in the adult reconstructive surgery. 66% of the surgeons report that they had some work-related injury in the form of neck pain, back pain, shoulder tendinitis. Similarly, even other studies which they say not only the surgeons, also the residents. So here the injury percentage is almost high as 87%. So you're definitely facing the work-related musculoskeletal disorders. So what could be the risks for a surgeon for the development of these work-related musculoskeletal disorders? So first foremost, it could be the awkward or the bad postures which you are adopting during the surgery, not knowing, obviously, because most of your attention is towards the surgery. So you don't even realize that you are adopting these bad postures, and it could be because of the poorly designed workstations, non-adjustable OT monitors, OT tables, the tools, the equipments when they are not well designed, poor work organization. So if your surgical team, if you know exactly what you want at that particular time, if it is not supplied, so that's a poor example of a poor work organization. So that could be another factor. The repetitive actions which happened during the surgery, the forceful actions which happened during the surgery, especially during the orthopedic surgery when you're using a drill, mallet, the vibration from the tools, and the environment. So these could be the reasons. So first, I would just be briefing of what could be done about the work practice controls and what is a physical ergonomics and what body posture changes you could do in order to incorporate good ergonomics. But before that, let us just discuss the neutral angles of the body. So the neutral angles during work, which are recommended by most of the ergonomic associations, are that the spine should be in the neutral, including the head and the thoracolumbar spine. The hip is centered over the foot. Then the shoulder is at a neutral angle without any flexion extension. The elbow is at a neutral angle and wrist should be at a neutral angle. Whereas in the seated posture, the back should be supported, the spinal angles should be straight, they should not be excessively flexed, extended, rotated. Again, the elbow at 90 degrees neutral, the hip, knee neutral, and the foot should be supported well. So these are the neutral angle recommendation. So when we do an ergonomic analysis, and when we do ergonomic analysis in any field, including in the surgery, when a surgeon is doing the surgery, we risk the ergonomic, we check the ergonomic risk. So with respect to the neutral angles, which I just mentioned, so higher your angles go, higher is your ergonomic risk. So as you can see, when your arm is flexed, it's approximately 20 degrees in both the direction, that is the lowest ergonomic risk. But as your arm goes on flexing more and more during the surgery, or if it is abducted or raised during the surgery, there is a higher ergonomic risk. So more you deviate from the neutral position, more is the ergonomic risk. Similarly, this is an example for the neck. So higher the neck flexion, which you adopt during the surgeries, especially during the open surgeries, higher is your risk. Similarly for the back. So based on all these scores in RULA, we have a final RULA score in which 1 and 2 indicate acceptable posture. So 3 and 4, mild risk, 5, 6, moderate risk, and 7 is it's a very high risk. So we did this preliminary analysis, and in arthroplasties, proximal femoral nailing, as well as spinal decompression fractures, we found most of this. You can see the ergonomic score risk 5, 6, 7. So basically they are moderate to high. So in the open surgeries, there is a challenging situation here. You can see there are the high neck flexion angles which are adopted. So basically in open surgeries, we have observed that there is more of neck flexion. Whereas in the whereas the monitor-based surgery, there is more of neck extension because of the inappropriate placement of the monitors. Not only that, but there may be a neck rotation, trunk rotation. So all these factors are different for the open and the minimal access surgeries. So these are a few pictures of open surgeries you can see, and this is a picture of the minimal access spinal surgery where you can see that the neck is rotated because the inappropriate placement of the monitor. So what controls could be done to incorporate the neutral postures? The first and the foremost thing recommended is place the patient as close to the surgeon as possible, as well as, if possible, that the tilting of the bed provision should be there. So due to that, this will reduce the forward lean of the surgeon. If the patient is placed very away from the surgeon has to excessively forward lean, so which could be one of the reasons for the poor neck and the back posture, excessive neck flexion, back flexion, and the neck pain which you may be experiencing. The other are related to monitor placement, OT table height, and footrest. So monitor placement, you know that it's a very important part in the minimal access surgeries which are done in orthopedic surgery. And there are a list of many minimal access surgeries. So we had done this analysis in which we have seen the spinal ergonomics during a minimal access surgery. And we measured the spinal ergonomics with the help of these sensors. And we have found that there is, as you can see in this picture, because of the monitor is not placed rightly, the monitor is placed to the extreme left. So because of that, there is excessive, first of all, rotation to the left side, lateral flexion in order to get the horizontal gaze position, extension because the monitor is high, and to adjust everything, the surgeon is also laterally flexing and rotating. So this is a classical example of a very bad posture adopted during the surgery. Similar thing could happen during the arthroscopic surgeries, monitor-based surgeries. So if the monitor is placed eccentrically, there is rotation of the neck, okay, as well as there is a lot of arm abduction if the monitor height is not, the OT table is not placed well. So what are the recommendations for the monitor height? The monitor, this is the motor axis, we call it, and this is the visual axis. So ideally, the motor axis and the visual axis should be in line with each other in order to avoid this deviation. The moment the visual axis or the monitor goes to the left or the right, what happens is that should be, there is excessive neck rotation, trunk rotation, and twisting, which happens, and that leads to a bad or an awkward posture. So that is about the twisting. The second thing is the monitor placement with respect to the eye level. So ideally, the monitor should be below the eye level or just at the level of the eye. Otherwise, high monitors lead to inadvertent extension, and extension has the highest ergonomic risk. So ideally, they should be placed. The upper border of the monitor should be at the eye level, or the center of the monitor could also be at the eye level, and the monitors should be tilted backwards by 10 to 15 degrees, because that's a relaxed gaze, or the relaxed vision is 10 to 15 degrees downwards. So the tilting of the monitor and the proper placement of the monitor would really help in this monitor based surgery. So the other options, now many of the monitors are on fixed TV trolleys, so that is a problem. So what could be the monitors? If they are ceiling mounted, then you can adjust them very well, or they are on adjustable surgical booms, even then they could be, the height of the monitor could be adjusted. Otherwise, all you could adjust is the placement of the monitor in front of you. The table height recommendations according to the Canadian Association of Occupational Health and Safety were they give recommendations for the table height. So when you're performing a precise task like a soft tissue dissection, during when you're starting with the proximal femoral nailing, you're dissecting the soft tissue. So ideal table height is just 5 centimeter above the level of the elbow. So for a precise task, slightly above the level of the elbow. For a light work such as screw insertion or during suturing, it is recommended that approximately the table height should be 5 to 10 centimeter below the elbow level. Whereas when you're performing heavy tasks such as drilling or impacting the component of proximal femoral nail with a mallet, the ideal table height is 20 to 40 centimeters below the elbow. So that should be the 40 centimeters may be too below, so 20 centimeters should be acceptable. So neutral postures with respect to, so I just mentioned right now, so if you have to do a prolonged task, 90 degrees is a favorable position, but for fine tasks, slightly more flexion, 110 degrees is favorable. And for heavy tasks, you go more towards extension, that is 30 to 40 degrees of flexion. Then shoulder position, and you can see because of the table height, because the table is slightly higher, the surgeon has to adopt excessive shoulder abduction. So again, this could give rise to shoulder problems as well as neck problems. And this is the unergonomic position which is adopted during the drilling. So you can see a very high abduction at angle. The elbow is not at a favorable position. So this could give rise to a lot of shoulder, elbow, neck, all these areas it could stress and cause pain. Now with respect to the wrist angles, it should be less deviated from this neutral position as much as possible. But sometimes what happens when you adopt high flexion angles, even the wrist goes into flexion. And ideally, we know that for a good grip, we require wrist extension and a slight ulnar deviation. So if you adopt these lower angles, then you would be able to adopt even ergonomic positions for the wrist. Now, certain recommendations when the surgeon is standing, there are certain problems which they feel, like when it is for a very long time, sore feet, lower limb edema, muscle fatigue. So footwear is a recommendation, with the footwear with a heel of 1 to 2.5 centimeters and which allows toe freedom. Anti-fatigue mats of rubber or vinyl are available. They distribute the weight equally, and they could also be used to reduce the foot discomfort. Foot rest are recommended, and shifting of weight from one leg to the other avoids excessive weight on one lower extremity only. Also, it reduces the strain on the back, which is caused because of the excessive lordosis, which you adopt if you do not use a footrest. And the footrest recommendations, it should be 15 to 20 centimeters in height and 20-30 degrees inclination. Now, another important thing, micro break incorporation. So when you are having, ideally in any ergonomic setup, it is recommended that a person takes a micro break from a continuous task. So surgery is no exception. It is also a continuous task. So micro breaks should be taken between 20 to 45 minutes for 1 to 2 minutes. But the micro break in this case should incorporate exercises. So we have incorporated this micro breaks in the OR, and in the micro breaks, typically you should do exercises like, for example, this is a stretch, this is a forward stretch. Because the wrist and the elbow is all the time in the flex position, we recommend the extension. Similarly, if you're again in a flexed position, if it's rotated to one side or tilted to one side, so this kind of neck movements are recommended. Same way for the, when you're sitting or when you're in a static position in a monitor based surgery for a very long time, the rotations. So we have an exercise protocol which could be followed depending on the type of surgery which you do. So you have in open surgeries where there is a lot of neck flexion, extension. During the micro break, it is recommended that you do extension. Then when there is a lot of internal rotation, then external rotation should be done during the micro break. When there is a lot of flexion all the time, then extension movement is indicated. So depending on what exactly the sustained position is, you have to stretch into the opposite position. So this is also an example of the layout and how the layout can. So this is our example of the hip replacement surgery. When the assistant is placed to the dominant side, it is easier. The surgeon does not have to rotate. Whereas if the assistant is on the non-dominant side, the surgeon has to rotate to take the equipments. So this could also increase the twisting. So your OR setup and the positioning of the OR team also makes a lot of difference in your ergonomics. So in short, again, I would like to summarize. So almost it's reported 1/3 of the orthopedic surgeons suffer from low back pain and neck pain, and the ergonomic challenges which are posed because of the surgery, which are physical, cognitive requirements of the task, high precision, newer technology with inadequate time for training, advent of minimal access surgeries, surgical workflow and team cooperation, all this could lead to muscle overload, fatigue, and higher risk for human error. And the few solutions I have discussed, there are lots of solutions. The solutions which I've discussed about the postures, layout, what should be done to relax, and how do you create a comfortable, surgical atmosphere in the surgical team. There are many other recommendations, but because of the time limitation, I would be discussing only this. These are my reference, and thank you everyone for a patient listening. And I hope you are able to incorporate at least a few elements to improve your OR ergonomics. Thank you, everyone.